Welcome back to Obcast. We're going to talk briefly about minor abdominal trauma in late pregnancy. And this isn't, I guess, as interesting as major trauma, and in emergency medicine we spend a lot of time thinking about trauma, but that's what makes this topic very important. It's important to understand what you need to do for a woman in late pregnancy who has sustained a minor blow to the tummy. Now, the first priority is obviously to perform a proper trauma assessment and check the fetal heart rate. But as I said, we're going to talk mostly about women who have only minor abdominal trauma, who are fine on your clinical examination. And the issue that we need to understand about this happening in late pregnancy is that these women can suffer a placental abruption, which is generally more obvious and clinically apparent. But they can also suffer what's known as feto-maternal hemorrhage, which is something that's almost clinically silent. Now, this is a cardiotocograph or CTG of a fetal heart rate pattern that could occur with a feto-maternal hemorrhage, and what this is called is a sinusoidal fetal heart rate pattern, which occurs in the setting of fetal anemia, which when there is fetal maternal hemorrhage, there is loss of fetal circulatory volume, and this CTG pattern could be picked up. Now, this pattern this CTG doesn't exactly show that. This is a lady in labour. You can see that she's contracting here, and actually she's on syntocin on augmentation. But I just wanted to demonstrate what a sinusoidal CTG might look like. In terms of our management of a woman with minor abdominal trauma and a fetal heart rate that's detectable, what we need to do is admit them for observation and repeat clinical review. Obviously, if they develop fetal compromise, then deliver them emergently, but otherwise continuous CTG monitoring, and that's usually for a minimum of 4 hours, because in the setting particularly of feto-maternal hemorrhage, this is a very small volume hemorrhage, which is going to take time to develop the manifestations. It's important to remember that Rh negative women need 625 international units of anti-D, and then good counselling on what they need to look out for. We'll briefly talk about the discharge criteria, assuming everything is fine, and that is a clinical review and 4 hours of CTG, and specifically no uterine contractions, membranes intact, no PV bleeding, a normal Kleihauer test, which, as we spoke about in the APH lecture, the Kleihauer test is a test for fetal cells in the maternal circulation and would be evidence of feto-maternal hemorrhage, and normal CTG, which I've given an example of here. Now, when these women are discharged, it's important to give them return precautions, and that's to look out for abdominal pain or contractions, PV bleeding, or reduced fetal movements. The last one there being one of the presenting features of a feto-maternal hemorrhage that's been missed. So that's a brief summary of minor abdominal trauma in late pregnancy. I hope that's been helpful, and I hope that raises your awareness that these women need a more prolonged investigation after their initial trauma assessment doesn't turn up any significant injuries. Thanks very much for listening.